Alterations in fluid and electrolytes, pathophysiology and management. Our body fluids are composed of water and chemicals, electrolytes, which are substances that carry electrical charges when dissolved in fluid, acids that release hydrogen into the fluid, and bases, which are substances that can bind with hydrogen. Most of the body water is going to be intracellular fluid, which is found inside the cells. Extracellular fluid is going to be fluid that is found outside the cells and may also be classified as intravascular, basically being the blood vessels, or interstitial, which is fluid that is located around the cells. The human body is comprised of 60% water. The water percentage of our bodies is going to be affected by our age, our gender, and the amount of body fat we carry. When we talk about intake and output, the fluid intake should average about 2,500 mLs per day, and we're going to get this from food and fluid intake, with a similar amount of fluid lost through urination. So we encourage our clients to drink at least 8 glasses of fluid a day, with water being the most readily available and least expensive fluid out there. Clients should always respond to their thirst unless there's a medical reason they should not. The thirst center is in the hypothalamus of the brain. Urine output per hour. When we have an ill client or a client recovering from surgery, we want to see at least 30 mLs per hour. If we have a client that has severe burns, then it's okay to see 20 mLs per hour. We do need to realize that an immeasurable amount of fluid can be lost in the body. This is done through the gastrointestinal tract, the skin, and through our respirations, breathing. If we breathe too fast, if we sweat too much, etc. This has caused insensible water loss. So insensible water loss is lost through the GI tract, the skin, and respirations. The translocation of fluid and exchange of chemicals, those electrolytes, acids, and bases in the body, is a continuous process. And this is done through 5 different processes. Osmosis is the movement of water through a semi-permeable membrane, and it will allow some substances to move into a more concentrated area. The body will attempt to make the concentration inside and outside the cells the same. We call this isotonic. Filtration also promotes movement of fluid through a semi-permeable membrane, but it's accomplished according to the pressure differences, and it determines how the kidneys will excrete or absorb fluids and substances. Passive diffusion is the movement of dissolved substances through a semi-permeable membrane from an area of high concentration to low concentration. Facilitated diffusion will require a carrier molecule to help move the substance. And then active transport will require ATP or adenosine triphosphate to push the substances from an area of low concentration into an area of high concentration. Osmolality is the concentration of dissolved particles per kilogram of water. Osmolarity is going to refer to the concentration of the particles in the body water. The higher the osmolality, the less water, and the higher the osmolarity, or the concentration of those dissolved particles. So if we have an excess of, if we have a minimum amount of fluid in the body, we have the less water, then our osmolarity, or our concentration of those dissolved particles, is going to begin to increase. Survival will be dependent on the body maintaining appropriate amounts and/or distributions of the fluid, electrolytes, and our pH levels. The body will make some adjustments to help keep these things in check, but when we're sick or we have a disease process or maybe medical interventions, these all have the potential to cause imbalances. So the way our body is going to make those adjustments are through osmoreceptors. These are neurons that are located in the hypothalamus that sense blood concentration. If the blood is concentrated, those osmoreceptors are going to stimulate the release of the antidiuretic hormone, also known as ADH, causing the body to hold on to fluid. It's antidiuretic, it's preventing diuresis. Or it will trigger thirst to gain additional fluid. If our blood pressure or blood volume changes, baroreceptors are going to be stimulated to release or suppress the antidiuretic hormone to help maintain fluid balance. Then we look at the renin, angiotensin, aldosterone system. These are chemicals that are released to increase blood pressure and blood volume through vasoconstriction or reabsorption of sodium. Natriuretic peptides are hormone-like substances that help reduce blood volume through excretion of sodium. ANP and BNP are going to be released when the heart walls are overstretched due to increased volume, and this will increase urine production. And FYI, when we're talking about heart failure, one of our key lab tests will be the BNP, the beta natriuretic peptide. When it is elevated, it will tell us the degree of heart failure. In completing a health history, the nurse has to be alert for conditions that can affect the fluid or electrolyte balances. The nurse should be alert to findings during the physical exam that may indicate fluid and electrolyte imbalances, and it's important to understand what the nurse aides can and cannot do. The UAPs, unlicensed assistive personnel. Remember that this is not going to be based on what you do at work or what you might have seen at work or your clinicals, but rather it's what is in the textbook. This is just a helpful hint. We will not be testing you on what you see at work or how you perform your duties at work. We will test you on what is in the textbook. In other words, the information that we are providing you. The unlicensed assistive personnel cannot assess, they cannot monitor, they cannot evaluate, they cannot plan care, they cannot teach, and they cannot treat. So when assessing priority, how do we assess priority? We look at Maslow's hierarchy, first of all. ABCs, airway, breathing, and circulation, always have priority in that order, excuse me, unless it is not relevant to the situation. Mental changes are also a priority. Safety is also a priority. Pain is going to be a priority after our ABCs, our mental status changes, and safety. Self-esteem is a low priority. To determine priority, look at it this way. If I don't take care of this situation first, this client may have a life-altering or life-ending issue. Or look at it this way. If I can only do one thing before I walk out of this room, what would it be? Remember, client care always comes first. We're going to do this before contacting our provider if it is relevant. There are going to be some issues where the client's condition is so severe that I need to contact the provider. When we look at vital signs, fluid volume excess can be exhibited with dyspnea, tachypnea, that bounding pulse, and elevated blood pressure. Whereas fluid volume deficit or a decrease in our fluid can be exhibited through tachycardia, tachypnea, and hypotension. Electrolyte imbalances can cause tachycardia or bradycardia. It can also cause weak and or irregular heart rhythms. Our acid-base imbalances may lead to changes in respiratory function, such as slow, shallow respirations or deep, rapid respirations. An elevated temperature can lead to fluid loss and an increased respiratory rate. Excuse me. Our intake and output. We need to assess our eyes and nose because this can indicate an excessive fluid loss or fluid retention. We also need to look at urine color. If we have urine that is very light colored, this can indicate that we have excessive amounts of fluid. We're peeing off a lot, or we just have a fluid volume overload. If we have dark colored urine, this can indicate that everything is concentrated and we may be dehydrated or have hypovolemia. Our body weight is also a good indicator. Daily weights with fluid imbalances are going to be very important. Daily weight assessments are considered to be an accurate measure of fluid volume changes, especially in the older adult. And again, like I said, an accurate measure of fluid volume changes. Body weight can indicate fluid loss or fluid retention. We know that 1 liter of fluid weighs 2.2 pounds. To obtain accurate comparable body weights, we have to weigh our client at the same time every day, wearing the same type of clothing, on the same scale, preferably before eating or drinking. We look at the client's skin, their skin appearance, color, temperature, and turgor is going to reflect fluid balance. Remember, skin turgor on the older adults should be assessed on the forehead, clavicle, or sternum due to loss of skin elasticity. Skin turgor on the back of the hand, I just encourage you not to do this on anyone because it's not going to be as accurate. Skin with excuse me, with a fluid deficit can be very dry. With um, dehydration, um, it could also be flushed. When we have fluid volume overload, our skin can be cool, it can be clammy, and it can be pale. Think about blowing up a balloon. Before you blow it up, you have a nice, dark, deep, rich color. But as you blow it up, that color begins to lighten as it is expanded with air. So correlate that with excessive fluids. With fluid volume deficit, we may also see the face being very pinched looking. It may have a drawn look to it. Eyes might be sunken, especially in your pediatric populations. The skin turgor will be tinted, and understand in the older adult, it will probably be slower to return to normal anyway. Skin with fluid excess can appear moist and edematous. The face may have puffy eyelids or fuller looking cheeks. Edema might be present, and that will reflect water and sodium retention. Pitting edema will be evaluated on that 4-point scale, ranging from +1 edema, where it's barely detectable pit, to a 4+ edema, where we have a deep and persistent pit that is approximately 1 inch deep. In severe edema, pitting edema may not even be possible because there's so much edema that it will not pit. You just can't press in on it. This is called brawny edema, where the tissue feels very hard. Edema is going to be best determined over the tibia, fibula, the sacrum, and the sternum. We need to assess mucous membranes. A tongue that will normally have one longitudinal furrow, so one furrow down the middle, but with fluid volume deficit, we may see multiple, multiple furrows. And the mouth will be very dry and sticky mucous membranes, especially in the cheek and that gum juncture. Realize that sometimes a dry mouth may just be because they're breathing through their mouth, or some medications may cause them to have a dry mouth, and it is not necessarily a reflection of fluid balance. With sodium excess, the tongue may also be very red and very swollen. We need to assess our veins. Vein filling can be an indicator of fluid volume. If the jugular veins are visible more than 3 centimeters above the sternal arch, fluid volume excess might be present. But if no distension is present, we may be looking at fluid volume deficit. Following elevation of the hands, note how long it takes for the veins to empty. Normal emptying is going to be 3 to 5 seconds. We lower the hands to a dependent position and then note how long it takes for the veins to fill. Again, normal is 3 to 5 seconds. If that time is increased, fluid volume excess may be present. So let's look at some diagnostic tests and procedures. Understand that nurses cannot order lab tests. There are a variety of urine and blood tests available to help determine that fluid and electrolyte balance or level. The urine pH will measure hydrogen, excuse me, it will measure the hydrogen ions, and this is going to help determine how the kidneys are responding to acid-base imbalances. We will literally be talking about acid-base imbalances pretty in-depth next semester. But urine is going to be more acidic when it's fresh and first thing in the morning. Urine is going to be more alkaline or basic after eating. Diet will be a factor in that a person who consumes large amounts of citrus fruits and vegetables tend to have alkaline urine, where a person who tends to eat a lot of meat tends to have a more acidic urine. The specific gravity is going to measure the concentration of the urine, fluid balance, and will also reflect your renal function. If we have a high specific gravity, this is going to indicate concentrated urine and fluid volume deficit. But do understand that as we get older, we are not able to concentrate urine as well. So an older adult may have a low or normal specific gravity even when they're dehydrated. Osmolality is going to measure the number of dissolved particles in a solution. And when we're talking the human body, in this case, we're talking urine. Urine osmolality is going to provide a precise measurement of the kidney's ability to concentrate urine. Dilute urine will have a low osmolality and generally will reflect renal excretion of excess water. Concentrated urine will have that high osmolality and generally will indicate renal conservation of water, or maybe in the case of renal failure. Urine creatinine clearance is going to be done with a 24-hour urine collection. Remember how we do a 24-hour urine collection. We get the order. The client will discard the first void because we don't know how long that urine has been sitting in the bladder. We're going to note the time and then begin collecting urine for the next 48 hours. We have to keep it refrigerated, and if the client unintentionally discards some of that urine, then we have to start the test all over again. This test is going to help determine kidney function, especially at the glomerular level. Urine sodium helps show fluid volume status and sodium intake. With large fluid intake or sodium restriction, the levels begin to fall. The level is going to be highest during the day. Urine potassium measures renal tubular function in a 24-hour specimen. Now let's look at the blood. Serum hematocrit is going to be the percentage of blood volume composed of red blood cells. The levels are elevated with fluid volume deficit because of that blood concentration. Levels will be decreased with fluid volume excess because of dilution. Serum creatinine is an indicator of renal function, and it is a better indicator than the BUN, or the blood urea nitrogen. High levels will indicate poor renal function. So it can be elevated if we're not peeing, or it can be elevated in the event of renal failure. So if we have fluid volume excess, we expect to see an elevated creatinine. The blood urea nitrogen can also provide an indication of renal function. Again, it's not quite as sensitive as the creatinine. Fluid volume deficit or poor renal function results in that elevation of BUN, and fluid volume excess will result in a low BUN. So look at it this way. If we have fluid volume excess, we can have an elevation of creatinine and BUN because the client is holding on to fluids. They're not peeing. In fluid volume deficit, we can have an elevation of serum creatinine and BUN because once again, we're not peeing because we don't have the volume to pee. Serum osmolality will measure how concentrated the blood is. Again, fluid volume deficit will result in a higher level, while fluid volume excess will result in a lower level. Serum albumin is that plasma protein that helps maintain blood volume. So albumin is protein. Low levels can result in a reduced blood volume and edema because we have a transfer of fluids into that interstitial compartment. Remember that space between the cells. The low serum albumin will allow water to shift into that interstitial compartment, and that will reduce our blood volume and start creating edema. Serum electrolytes are going to be discussed more thoroughly in a different presentation. Nursing priorities when we're discussing fluid volume deficit or fluid volume overload include impaired gas exchange, decreased cardiac output, fluid volume excess, and fluid volume deficit. Now, multiple nursing diagnoses could be used, but these are the top 4 diagnoses. The nurse will need to be aware of what fluid and electrolyte imbalances can lead to and work to prevent them. Complications of fluid and electrolyte imbalances can include death, cardiac dysrhythmias. Electrolyte imbalances can cause cardiac dysrhythmias, and fluid volume deficit and excess, in addition to dysrhythmias, are going to affect cardiac output, which is the amount of blood that our heart puts out every minute. Respiratory compromise. This comes from a decreased cardiac output, and electrolyte imbalances. They affect respiratory function up to and including respiratory failure. And neuromuscular complications might cause confusion or muscle weakness. So something I want to point out is when we're talking a imbalance of sodium, we're talking fluid volume overload or fluid volume deficit because water follows sodium. When we're talking an imbalance of potassium, we're talking potential cardiac dysrhythmias, whether it's too high or too low. When we're talking calcium, we're talking about muscles. So it can potentially cause muscle cramping, muscle twitching, muscle tetany, that sustained contraction with low levels. If we're talking high levels, now we're talking bones because the calcium is pulled out of the bone and makes the levels high in the blood. So that can weaken our bones When we're talking magnesium, one of the main things I want you to remember is this has to do with our reflexes. Now, these are not the only things that these imbalances are going to encompass, but these are some of the most important things about these electrolytes. You need to remember these. And we'll go over those more thoroughly in another presentation. So, what do we do with client education? We always provide education to our clients, but when we're providing education, we also need to assess for those sensory deficits. Make sure that you take more time and assess for understanding, especially in the older adults, and always provide education to the client first. If a family member does all of the talking or answers all of the questions, I recommend that you listen politely, then specifically direct questions to the client. For example, now that I've heard from your daughter, I need to hear from you. If it's appropriate during your education, do a demonstration and then ask for a return demonstration. That is going to be more indicative of understanding than almost anything. It's also important to provide written instructions for the client to take home for review. Daily weights are an accurate way to monitor for fluid loss or retention. We teach our clients to do their daily weights to monitor their fluid balance. This is a pretty accurate way. Weigh before breakfast, in other words, before eating or drinking. Weigh at the same time daily, on the same scale, wearing the same type of clothing. If there's a weight gain of 2 to 5 pounds in 1 week, or whatever the provider deems appropriate, the client should be instructed to call their provider. Instruct the client on appropriate hydration. That amount will be dependent on their body weight, their health status, their activity level, and the environment. Remember, sodium encourages fluid retention. Sweet and dry foods are going to stimulate thirst. Assure the clients are aware of their dietary resources of electrolytes and what should be avoided or encouraged.